I'm Dr. Mark Sue, and welcome to the Functional Medicine Reality Podcast. Join me and our community weekly as we bring you unfiltered health from inflammation to longevity. Real stories, real people, real solutions. Experience real-life health changes from both patients and practitioners, and learn how to turn cutting-edge information into real results in your own life so you can feel better, live longer, live healthier, and be confident and clear in your healthcare choices. Let's get real and get results. Hey friends, this is a really important topic I have for you today, especially for you if you are a prescribing practitioner, meaning you can write for prescriptions, all right? And that infers to me that you have a certain kind of license, a certain kind of medical license, but it's also really applicable as really meaningful, deep insight for those of us who, as patients, who have been around the functional medicine world, you've wrestled with a lot of chronic symptoms for a meaningful length of time and have done a lot of searching and digging to try to get better. This will be really meaningful to you as well, all right? And it is as applicable to how you interact with your practitioners, whether current ones or future ones, all right? So here's the topic. The term for today is the differential diagnostic list. All right, not to get technical, but we're talking about the differential diagnoses that a presenting patient might have for any given singular symptom or multiple symptoms. And the more symptoms a person has, the more complicated and lengthy that differential diagnostic list becomes. All right, so what is this differential diagnostic list? In conventional medical training, this is a really important part of what we learn to do in evaluating patients. It is the list of possible diagnoses that might explain the person's condition. So let's keep it really simple today, and let's just say we're talking about abdominal pain, all right? So in conventional medicine, if someone has pain in their what we call left lower quadrant, all right? Down below the belly button, the left side, the lower abdomen, that quadrant, okay? Just above your left hip, all right? If a patient presents with left lower quadrant abdominal pain, as an adult, let's say as someone over 50, 55 even, the first thing that most everyone's going to think about is diverticulitis, all right? However, when a patient then says, it's been going on for 3 or 4 months, all right? Now suddenly that shifts things. The likelihood of it being diverticulitis drops down the list in my book. I think most of my colleagues would all agree, because the likelihood someone's had diverticulitis for 3 or 4 months is pretty stinking slim, all right? So all these factors that we as practitioners, clinicians are asking patients about, how long has it been going on? Where is it? Where do you feel those symptoms? Is it all day and all night? Is it associated with eating? Is it associated with exercise? All these different factors, they start to influence our thinking, and it's helping us narrow the differential diagnostic list down to the top 2 or 3 most likely causes, okay? So if somebody just says to me, I've had left lower quadrant abdominal pain, but they don't tell me anything about how long it's been, how bad it is, and any more detail, the differential diagnostic list is lengthy. Diverticulitis, sure. And again, let's just keep it within a 50, 55-year-old person, okay? Sure, diverticulitis, some sort of non-specific colitis, just inflammation of the colon. Could they have some kind of ulcerative colitis or Crohn's disease as an inflammatory bowel disease? Could it be muscular, all right? Could they have gotten hit playing sports or something like that? It's a musculoskeletal issue. Could it be that they have a kidney stone? Could they have a UTI or bladder infection? Could they have pyelonephritis as a kidney infection? Could it be referred pain from somewhere else? It's not likely gallbladder on the flip opposite right upper side of the abdomen, but some other referred pain from somewhere else in the abdomen, okay? And so right there, the list can go on even further. Could the person simply just be chronically constipated or meaningfully constipated, right? All kinds of possibilities. But here's the take-home message, okay? If you're a prescriber and you work in the functional medicine world, as I do and my colleagues, my close colleagues, it is really easy for us to think about all the various possibilities of abdominal pain, right? Especially in the functional medicine world, we start going into thinking about SIBO and SIFO, food intolerances, food allergies, subclinical, hard to diagnose, less detectable Helicobacter pylori, parasites, the mold mycotoxins, even unusual symptomatology with Lyme disease, especially if there's a bunch of other symptoms going on. The differential diagnostic list is very different and way more expansive than even just the conventional medicine differential diagnostic list, right? And it is really easy for us as prescribers to get, dare I say, caught up in or sucked into that differential diagnostic list in the functional medicine world. But we got to remember, when it comes to with functional medicine, we're talking largely about chronic inflammatory conditions, all right? And we cannot, as prescribers, overlook the prioritization of those acute problems that can be big and bad, and that can get us really in trouble if we overlook that commonly are in the more conventional medicine world, okay? First and foremost, if you're a prescribing practitioner with one of those more conventional licenses and all that, state board licenses and all that stuff, you're up a creek. We are up a creek if we're not thinking about the common diverticulitis issue or cancer. God forbid we overlook cancer, okay? So the take home here for us as prescribing practitioners is the following. We gotta remind ourselves and teach ourselves to remember to go through the conventional common list of differential diagnoses at the same time as, if not commonly even before we think through the chronic inflammatory sort of functional medicine diagnostic list, okay? Differential diagnostic list. When we know our patients really well, or we've been seeing them regularly, all right, we can have it's a lot easier for us to skip past, if you will, or reassure ourselves that we can rule out those conventional topics because they're describing an extremely familiar and recurring symptomatology that we are very familiar with, okay? But even if you're working with a patient that you've known for 2 years and you've seen them 10 times or more in those 2 years, if they describe symptomatology in the same location or in a similar way to what they've experienced before, but it's somehow different, especially more intense, like in this case, yeah, they've had abdominal pain for off and on for 2 years and you've known it, all right? I've known it. Let me put myself in that shoe. I'm the practitioner and I've known it. It's easy for me to just pick up on where we've left off on all those conversations about all the issues, SIBO and on organic acid testing, the Clostridia and whatever else, okay? But I got to be attuned to that there's something different about what they're describing here today, and I cannot overlook diverticulitis. And if they are, and I've been working with them for 2 years, but I knew at the beginning that they've never had a colonoscopy, and now the symptoms are different. Maybe they're having a little bit of bleeding. Yeah, it's easy to chalk it up to hemorrhoids, but God forbid, and it is not in the patient's best service if I just assume that it's internal hemorrhoids or whatever else. We have to do our due diligence and rule out those big bad things, okay? Now, so first and foremost, it is not in the patient's best service to overlook those topics. And number two, you and I are going to be in bad places of liability, especially as those with more conventional licenses and such, with different kinds of expectations by the public's eye at the very least, and certainly in a court of law, than functional prescribers who are non-functional practitioners who are non-prescribers and who many patients sort of self-select to see because they are outside the conventional box. But generally speaking, they're at less liability risk of a lawsuit, all right? Now, the take-home message for you as patients, for any of us as patients, is when we've wrestled with the same symptoms for a long time or recurring symptoms, okay, it is also really easy on the flip side of the coin for us to be chalking up our symptoms to the same old, all right? Oh, I'm having abdominal pain again. Oh, it's that whole, my PCP calls it IBS, but I know it's more about SIBO and I've had some H. pylori at times and whatever the case may be, okay? But we have to be attuned to recognizing when the symptoms vary, even just by a little bit. Maybe the symptoms I'm having now aren't triggered by the usual triggers. Maybe it's not at the same time of year that I always have those symptoms. Maybe it's 20%, 30% more intense than it usually is, all right? Maybe in this case with abdominal pain, I have bleeding, which I've never had before, or I haven't had in 5 years, but it's not new, but it's been 5 years, and so I'm minimizing that. It is easy and common for me as that patient to just fall back into that familiar thinking and just make assumptions. All right. It's a lot of work, whether you're a patient or practitioner. It's a lot of work to constantly clear the slate, if you will, talking to the other half of the coin, whether I'm a patient talking to a practitioner that I know well, or practitioner talking to a patient I've seen for a long time. It's a lot of work to clear the slate and say, let me just go through my checklist methodically and be sure I've thought about A, B, C, D, and E, even though I've thought about that for the last 5 visits in a row and we've ruled those out. It's all part of the work, and it's in the best service of the patient, and it's in the best service of yourself as a practitioner to not put yourself in a precarious position. It is extra work, but it is worth it on all levels. All right. And for those of us who have been around longer and more experience, yeah, we might be able to do that faster or with more reassurances. But in the end, the more comfortable we are, just watch out. All right. Being comfortable is not always a good thing. It's nice at times. We have more experience, we're more comfortable, we're more familiar. The learning curve is lower. There's fewer learning curves, but complacency can be a real meaningful and stealth enemy, all right, for us as practitioners. And again, as patients, not only are you doing yourself a better service by not necessarily just making presumptions all the time, but when you present your symptoms to practitioners, especially those who you've been working with recurrently, it's by presenting it with presumptions and labeling it as this or that, or inferring that you know what it is and that it's the same old, it insinuates and infers and only serves to cause the practitioner to start thinking in those same lines and make assumptions. But in the end, this is not meant to like create ourselves extra work and just be all liability oriented. But first and foremost, for the sake of clarity within ourselves and with our practitioners or with our patients, it's important to just be clear within ourselves first and foremost about how we're thinking these things through, and then do our due diligence, even if it only takes a minute or so, to rule out this and that by verbalizing and communicating clearly within each other that yes, this is the same as usual, that yes, these things that you're asking about are not anything new, and correct, I'm also not bringing to the table as a patient any new symptomatology, and so you can be reassured that we don't need to think about other topics. All right, the differential diagnostic list, meaningful step in the evaluation of any patient, no matter if they're a new patient or have new symptoms, or it's a well-known patient and someone who is presenting with what seems initially like the same symptoms as usual. All right. That, my friends, is definitely the reality of medicine, and especially the intersect of functional and conventional medicine. It is not an easy place to be. I am very fulfilled with it, practicing in both worlds, being open to all tools in both conventional and functional medicine world. But man, it's many times even more work. Worth it, but it's more work. So practitioners, let's just do ourselves a service and guard ourselves and remind ourselves, all right, about best practices in patients. Please be aware of the kind of impact you can have on your practitioners by the way you present information. And just know that it's not always the same old. All right. Peace to you guys, and we'll talk again next time.
So fresh, just the way you like it.